Tracy or Tanisha, can one of you guys just talk so I can make sure I can hear you?
Hello.
Are you talking right now?
Yeah. Can you not hear me?
If you are, I'm not hearing you. Let's see if I turn this up if that works.
Hello, hello. Can you hear me?
Oh,
Can you hear
I
me?
think yep, I can hear you.
Okay.
Awesome. All right. For a second, I thought it was Jesus. All right.
Do you want me to sign in so I can?
It might be helpful. So Tracy and Tanisha, you can try to talk over. It's a little hard to hear you, but I can kind of hear it. If you have any specific questions, Heidi's going to log in to see about comments. All right. And I guess we can wait for Chitty as well to get connected. Chitty, can you hear me okay?
Yeah, I can hear you.
Perfect. And I can hear you. All right. And then does this work? Oh, does it work? No. All right. All right. So exam 2 is done. We're going on to module 3. This content is interesting because it could get as complicated as you want it to be, or it could be as simple as you want it to be. Actually, I'm a big fan of making things simple. Oh, I am. And if you don't think it's simple, then that's going to be an issue. Jesse. Can we turn the lights off? Yes. So. Yeah.
Sure. You guys are really setting the tone for me.
Yeah. Heidi's going to be out halfway through. All right. So yeah, this content could be as simple or as complicated as you can possibly make it. I feel like this is a good opportunity to simplify the content and actually hit on a few things with the diagnostic process and how we should think about patients when we approach them in our clinical care. So there's going to be a little bit of elements of diagnostic reasoning embedded throughout this. Alrighty. And so let's see. Here's our modules. I'm going to just bring this down. All right, there we go. So here's our modules. So as you can tell, we've kind of already reviewed endocrine physiology. We're going to understand how we're going to manage and treat these patients. The last 2 points are going to be kind of the things that we're going to I'm going to stress on a little bit more today, which is just kind of having a comprehensive list of a differential diagnosis and then using this concept of illness script, because it will be very helpful as entering into clinical practice to have this concept in your mind when you approach patient care. Alrighty. So we're going to start with the case. So this gal is a 74-year-old female. She's got a history of DVT, PE, hypothyroidism, TIA, hypertension. She was recently diagnosed with the stage 4 diffuse large B-cell lymphoma. She was actually admitted to start her regimen, which is like RCHOP, and she was found to be weak and encephalopathic on admission. So she was actually just coming in for a routine admission, and they saw that she was weak and encephalopathic. So the exercise we're going to do is we're going to go through one by one, and you're going to name one differential diagnosis. Can be a problem or a specific diagnosis. You're going to name one test that you would use to either rule in or rule out that disease. And I think it might be easiest to start with our people who are zooming in. So Tracy, do you mind starting?
Yeah, I would say, oh my gosh, I'd want to draw a, what's I'm gonna call it? An ammonia level.
Okay. And what's your diagnosis, or what would your problem be that you're looking for?
Hepatic encephalopathy.
Perfect. All right, Tanisha.
That was actually the one I was going to do.
All right. So what would you do?
Let's see. Let's see. I don't know, maybe check a TSH see where those levels are.
Perfect. So what are you looking for?
If the hypothyroidism is being treated properly.
Perfect. So worsening hypothyroidism. I like it. Chitty.
Yeah, yeah.
So
So I was gonna say the same thing, but we can also go further to check for the T3, T4 to see whether there's whether he's having problem.
yeah,
We can also rule out since he's having weakness and encephalopathy and dig more on the history, the physical history, that like the previous history, and see what's going on. But I will lean more on doing more tests on the T3 and T4 on the TSH.
is there any additional tests that you would like? Let's say that Tanisha was the one working the night before, she sent the TSH with the reflex to T3, T4. What would be a test that you would do so that you don't get pigeonholed into hypothyroidism?
To make sure he's not like I don't know whether there's any test to make sure he's not having any adrenal insufficiency, AI.
Oh, I like that. Great. Adrenal insufficiency. So do you know what you would send?
I don't remember right now. I know you still send the TSH and the T3, T4, but I'm trying to remember what we can send for the adrenal insufficiency.
Well,
for the steroid too, I don't know. I think I'm mixing everything up.
Yeah, that's all right. You bring up a great differential diagnosis, and we'll actually go over testing in this lecture. So that's a great segue we'll have at one point. All right, and then we'll start with Ebby.
So, taking from PE, as the encephalopathy, I would like to do CT just to rule out that those tests were not caused by maybe less, not caused by PE because it's not having enough perfusion, so causing the confusion and stuff with the encephalopathy. So I would say CTA to rule out PE.
All right, CTA to rule out PE. I like it. You looked at her history and kind of counted that as well. Allie?
I'm worried about Cushing's and I would like a cortisol level.
All right, cortisol for Cushing's. Kendall?
So she's coming in for chemo. Let's do CBC. She might be weak because she's neutropenic. She might have an infection.
Okay, neutropenic fevers, infection. I like that. CBC. Alex?
I'm thinking about like metabolic acidosis or ABG or CMP.
Perfect. All right, ABG, metabolic acidosis. All right, Sarah?
I was just reading.
Oh, yeah, sorry.
Basically what they already all said.
Yeah, perfect. And that's the kind of the exercise here, right? Because people will work before you and they will send tests, and then you're like, you have to think of new things. So like that, so CT had to rule out intracranial hemorrhage or cerebral edema. Kaden?
To go on kind of infection, maybe meningitis and LP.
All right, so we have meningitis, LP.
Well,
Rachel?
I was also going to say, but to do blood cultures.
Blood cultures, infection. Awesome. Jesse?
Sarcoidosis.
All right, sarcoidosis.
We have to dig deeper.
Yeah. It's gonna get more exotic as we get through. All right, sarcoidosis. So I'm assuming neurosarcoid is what you're going with?
Well, yeah, if it was going to be causing the hypothyroidism, that might be related to it.
All right, so yeah, do you know how you would rule that in or rule that out?
Well, something, yeah, you could do a D-dimer, a bronchial alveolar lavage.
Nice. Oh, okay. Jesse's gonna bronch the patient in the ED and send a VAL for a D-dimer. I like it. All right, Lydia. Perfect. How would you roll that in or roll that out? Or is a head CT going to pick up all tumors? So what else could you send or do? Perfect. MRI. Do you know if you're going to do it with or without contrast? Damn it, Rachel. Phil? I like it. It's simple. How are you going to do it? How are you going to roll that in or roll that out? Perfect.
I'm guessing we already checked the thyroid levels. So.
Yeah.
We haven't checked another very basic lab.
We do a chemistry.
Perfect. Chemistry. Hypernatremia. I love it. All right. See, that was great. Got your brain stretching. We got Jesse ruling out neurosarcoid. Love it. All right. So upon admission, she was diagnosed with a urinary tract infection. She had a dirty UA. And then based off this regimen, diffuse large B-cell lymphoma has a high risk of entering the CNS. So she underwent an LP. And when they do LPs on these patients, they will just give them their intrathecal chemo. So she also got intrathecal chemo that happened on hospital day 5 through 7. And then she had an IVAD placed because they were planning on getting her set up for her regimen. She had improvement from her urinary tract infection. Pretty straightforward. And then on hospital day 8, she was transferred to the oncology ICU for neutropenic fever, hypotension, GI bleeding. Her physical exam, she was very lethargic, but she would waken to voice. She was oriented only to place and time. She had abdominal tenderness, diarrhea, and she was noted to have very large external hemorrhoids. She received some IV fluids, which improved her hypotension and lethargy, but she was made NPO overnight in anticipation for a scope in the morning. All right. Then things get a little interesting. So hospital day 9, she had a routine BMP that morning that showed a sodium of 161, and it was 147 the day previously. So when you have a patient whose sodium jumps from 147 to 161, what should you do first?
Did she live?
Yeah, she lived. Oh, people do a lot more fluctuation than this and do well. Recheck it, right? Because the lab screws everything up. No, but yeah, sometimes you're running NS, right? You run NS in a IV and then someone draws from that IV and sends in. It's a little bit more salty. We did recheck it. It was 163. So, all right. Anything else we should be doing? Maybe before panicking or maybe after panicking. I don't know where the panic fits in this.
What's her volume status?
What's her volume?
You want to always know like with hyponatremia.
Yeah. So that's a good question. You know what? Hypernatremia, guys, is boring. It's not as sexy as hyponatremia. It doesn't have all these like major, like you have to know if they're hypo or hypervolemic. There's only one thing wrong. You don't have any water. Your water is gone. And there's a few reasons why. You either diuresed it or you're not getting enough. All right. So what else should we be assessing for if you have a patient whose sodium jumps up like that?
The neurostatus.
Yeah.
I feel like that's really high sodium. Like I know it's look bad type of thinking, but I want to like do something.
Exactly. Look at her neurostatus. What is she doing? She's still disoriented time and place. But she's following commands. She doesn't seem like she has elevated ICP or anything. But that's a very important point. So recheck the lab, assess the patient. All right. So what is the initial treatment for hypernatremia? I already told you what the problem was. So exactly. She just needs water. So how do we give patients water? Yeah, entirely how? Right, so we have PO. What if she's too confused and can't drink water?
IV dextrose.
Yeah, D5 and water. Good job, Jesus. Got that. Actually, was that Tracy?
Yeah, that was me.
Okay. All right. So she was started on D5 at 150 an hour, and despite that, continued to rise, 163. This provider actually did start it before rechecking it. And then someone's like, well, you should recheck it. And then they rechecked it. So it was 163. And so then they increased it to 250 an hour. And by this point, they were like, okay, let's just get a urinary catheter and see what's going on. So I was actually the bedside nurse for this. I placed the urinary catheter and sent a serum and a urine osm at the same time. All right. So the serum osm is elevated. The urine osm is decreased. And this is in the setting of hypernatremia. These findings are consistent with which disease process and why? Diabetes insipidus, correct, and why? Yeah, right. And if you or I weren't getting enough water and our sodium jumped up to 150, what would our urine osm look like? It'd be up, right? It'd be very concentrated. We wouldn't be pouring extra water out if our sodium was elevated, right? Now, my question is, did I have my next question on this slide or the next slide? All right, so the diagnosis of DI can be made when you have a sudden onset of hypernatremia with those lab findings. All right. And then we unknowingly administered this diagnostic test by making her NPO for a GI bleed. And then ironically enough, we put her platelets up to 50 and she stopped having a GI bleed. But we found another problem during this whole thing. So we kind of already went over why the urine osmolality is indicative of DI and what you would expect under normal conditions. So why are we now just noting hypernatremia?
Probably just been drinking water like a fish.
Perfect, right? She has a working hypothalamus. She has osmolar receptors in her brain that tells her to drink water to keep the perfect osmolality. And we said, you don't get to drink water. We got to scope you for a GI bleed in the morning. See? Perfect. You guys are nailing it. And it's really funny because these people, if you let them just drink, it is so much easier to correct their sodium than doing it with IV or PO or like doing like the integral feed waters and stuff. So DI can be central or nephrogenic. So we gave 1 mic of desmopressin and then we reevaluated her urine studies. And it showed that her urine osm was increased after we gave desmopressin. So in this scenario, is that consistent with a central or a nephrogenic DI? And why? Exactly. Perfect. So the plot thickens, and so does the MRI findings. So we found some thickening of her optic chiasm and the superior pituitary infundibulum. There we go. I have to look at it, otherwise I can't say it. And they feel like most likely due to her lymphoma. And then I think we already said that part. Oh, DI is a disease of what hormone? I think Sam said it. Yeah, perfect. All right. Oh, I think we already hit this part too. Let's see. Oh yeah, this is a little bit more into the principles of management. So yeah, initially you have to bring that sodium down quickly. Like if it jumps overnight very quick, then you can bring it down very quick, right? It's not like this hyponatremia where the patient's been out there for weeks with like a low sodium, you don't know where they're sitting at, right? Like if it jumped within 6 hours, you can bring it down within 6 hours, not less than what it was, but you can bring it back from like 161 to like 145 or 147. That's the target that's acceptable. And then desmopressin therapy, the way it kind of fits depends on how quickly you can reverse the cause of the central DI. If, for example, like in this scenario, we have it due to a lymphoma, she already got her intrathecal chemo and she should respond to it. So as long as that cancer hasn't obliterated her pituitary gland, there should be some form of recovery. So she might just need desmopressin in the meantime until her pituitary gland starts producing what it needs to. So what ends up happening is You manage it by letting people just kind of regulate themselves during the day. They can drink water, and then at night they give themselves desmopressin via like a nasal spray. We have to be very careful with desmopressin. You can't just like up and like start a high dose because you can make things much worse. You can give them what disease state? Yep, perfect. SIADH, which would make you hyponatremia, right? And then the way we do it in the ICU really is we just do IV because we do everything IV. It's more critical, right? We want to show we're serious about what we're doing, so we give it IV. But you can do it intranasal as well. And also I think it depends because in the ICU, most of the time people start to get delirious, and if you start at nasal, then you got to go to IV and it gets tricky. So here's kind of the dosing. You start at 5 mics and then you increase. Patients will respond differently to the medication. So you have to just kind of see how they respond to it. And then if for some reason you started them with nasal and they're not responding, then you move to IV. Alrighty.
You're saying like, see how they respond, would you mean like their neurosymptoms get better or they're just putting out less urine?
Putting out less urine, right? Yeah, because if everything's cush and working and it's really the dosing at nighttime is really just so that they don't have to get up and pee every like 2 hours. And so, because they'll regulate themselves during the day. In the ICU, it's a little trickier because there's like, they're not fully with it half the time and you're having to give them water and then you're chasing your tail with the water. And so sometimes you might just be dosing it like every 12 hours or just, yeah, every 24. Yes.
Tracy's just asking for you to repeat what the students say. Because they're not taking a lot of that.
Oh, what did Kendall say?
I said what you said you're looking for.
Oh yeah.
A response.
Oh yeah. Yeah. So Kendall was asking about response to desmopressin, like what are we looking for? And I said we're looking for mainly at night just to decrease the urine output. By that point, they should be relatively stable. In the ICU, obviously, we'd be following something closely like sodiums and isonos. All right. So hindsight is 2020. So this is a graph that I made of the patient's sodiums from her initial presentation to her lovely stay in the ICU. So as you can tell, on hospital day 4, she's actually made NPO overnight for the IVAD placement, but she started out relatively normal and then she jumped to relatively high normal. So no one noticed that she had a 10-point increase because she went from 135 to 145. And then she got her IVAD, she drank herself back down, and then she skyrocketed once we made her NPO. All right. And then if you look at her eyes and nose from the previous day, she was drinking 6 to 7 liters of water, right? It's really interesting because when you're looking at this after they're admitted to the ICU, you're like, how did like no one notice that this patient's drinking like 7 liters of water a day? But that's the beauty of hindsight, right? Like to us, like after the fact, we're like, oh yeah, duh, DI from lymphoma infiltration. So, oh, can't remember if there's another point I had on this. I don't think so. All right. So on hospital day 9, so she was starting to get better, but then she developed fevers and then got hypotensive. And then she ended up on 2 pressors. So with the information known, what is your differential diagnosis for her hypotension? And a differential diagnosis means more than one thing, just to clarify.
Dehydration be one.
Perfect. Infection. All right, so we have hypovolemia and septic shock. Do you guys have a framework in your mind when you work up shock during clinical? Did I already share my framework for shock workup? I spelled.
It was in the
Yeah.
right.
Shock.
Oh, shock.
Yep. Septic, hypovolemic, obstructive, circulatory, other kinds. Right. So
She does have a cardiac history.
Yep.
Work up cardiac.
Notice how by having a framework, how quickly you can pull that information from your mind and just apply it to a patient. That's why it's important to set these things up in your head when you go about patient care, because sometimes your patient doesn't have time for you to be like, well, let's see, up to date. Well, where's shock? It'll get better with time, but you have to have some working knowledge that you can bring to the forefront of your mind. All right, because some things are time sensitive. All right, so we have hypovolemic, we have septic, are kind of our relating things. We also know that there is a Goomba on our pituitary gland. Is that important for any reason? Does it secrete anything? Just a couple things. Anything that would make you hypotensive if it wasn't working? Yeah, it's a good term for. Yeah. Yeah. Interestingly, she had a history of hypothyroidism, so she was already being dosed with, levothyroxine. And then hypopituitarism is the diagnosis, but what from the pituitary gland would make you hypotensive if you don't have it anymore? Yep. Adrenocorticotropic hormone, which releases glucocorticoids, and then catecholamines are released by the adrenal glands, but they're not driven by ACTH. No. So, alrighty. So she was unresponsive to fluids. She was on 2 pressors at that point. We did a stim test. And then here's all of her labs kind of laid out here. So here is the ACTH less than 5, the FSH 0.2, which is, did I put the normals? No, I cut them off. Sorry, there's normal values here. Excuse me, I'll add the article that I pulled this from so that you can see. And then as you can tell, her thyroxine level is actually therapeutic, even though her TSH is less than 0.01 because we were replacing it for her. And then her growth hormone is less than 0.05. So the stim test, has anyone helped perform a stim test? Do you want to walk through, Kendall, what that entails?
Yeah, you draw a baseline cortisol level.
Oh, it's right.
Or is the baseline cortisol level, right?
Uh-huh.
And then you give ACTH, and then I think maybe 30 minutes or an hour later.
Both.
Draw another, okay, 30 and then 1 hour. I haven't done them a long time, but you just draw cortisol, the cortisol levels at those times. Just because if you're just getting a cortisol level, like we know that fluctuates throughout the day, so that doesn't really give you any good. Like it doesn't have a lot of clinical value.
Yep.
Until you then do, if you're stimulating it and you want to see it.
Yeah.
The cortisol levels change.
Perfect. So baseline, 30 minutes, 60-minute cortisols. So this patient, their serum cortisol starting out, do I have it? Oh, I do. Was 38. And then we gave the ACTH or the cosinotropin, brought it to 39.7 and then 40 an hour later. What are your guys' thoughts on that?
It went up, I'm sorry, I can't see that. It went up, but not by much.
Yeah, exactly. It didn't have a great response. What's our thoughts on that?
Well, I guess I don't know how much it should be, because I don't know.
Yeah, perfect. We'll go over that. But it didn't have a robust response. You would expect like a point, like jump of like 18.
Okay.
And so 1 to 2 is not a great response. So it also shows that maybe the adrenal glands aren't responding as well to the ACTH. All right. Oh, is that here? Oh, no, this is so you can indicate someone's having normal adrenal function if their cortisol is 18 to 20 before or after administration, but that's a general guideline. There's this term called relative adrenal insufficiency, which essentially just means your adrenal numbers may look normal, but they're not responding appropriately to the clinical context. All right. Oh, is there another question in the chat or did this? Oh, no.
I think that's when I responded.
All right. So on hospital day 10, she became hypokalemic. She had a 3-second run of VT. She was, I'm pretty sure I meant to say untreated on that because it was only 3 seconds. And then she became increasingly somnolent. So she was intubated for airway production. And then she continued to have fevers and hypotension. So they actually added empiric fungal coverage. And then that night on hospital day 11, she went into Torsades, requiring CPR. She got ROSC in 2 minutes with a dose of magnesium. So why do you think she went into Torsades?
Was her max low or was it?
Yeah, I mean, we're giving people lots of drugs, and at the Huntsman, it's what we do, right? Circle of hope, circle of drugs. What? I'm sorry.
So why did you say she went into Torsades?
We haven't.
Oh, okay, great.
So why do you think she went into Torsades?
My best guess was like hypomagnesia, but like she's just all kinds of sick. I don't know. Like I feel like, oh,
If she was hypothyroid, that cause it?
They were treated.
Yeah, it's being treated, so probably not likely to be contributing to Torsades. What outside of this context, outside of like endocrinopathies, what causes Torsades? Yeah, and in combination with prolonged QTC, right? Yep. So she's pouring out a ton of urine from her DI. She's losing K, mag with that. And then I'm sure she's getting some form of prolonged QT medications. And so that combination for this patient, no bueno, which is why she went into Torsades. So despite having small improvements, she ended up passing away on day 14. So as you can tell, things kind of get complicated when you have this system in the background that's just kind of fighting you the entire time. And then
what killed her?
septic shock. Yeah. So unfortunately, I don't remember what her infectious source was. I think it was pneumonia, hospital-acquired pneumonia. She did have a UTI, but that was treated by day 5. Yeah, she passed away on day 14. To be completely fair, though, this case is from, I wrote it in 2016. And so that was like quite a while ago.
Still happened.
Yeah, but it's still applicable, right?
Older than 5 years.
Yeah. So interestingly, I wrote this case study during my first year as a student, mainly because I was like, this is a complicated system. I don't understand half of what's going on. I don't know what relative adrenal insufficiency is. I don't know how our thyroid contributed to it. I actually don't really know that much about DI. So I took that opportunity to write this to share with other nurses that there are some things that we need to keep an eye out for on our patients that aren't as obvious, right? Like that fluctuation of a sodium from 137 to 144 didn't dawn on anyone as odd, but it's an 8-point increase, right? So despite being normal, that's abnormal, right? Same thing with urine output and water intake, right? Like you're like, oh, the patient's peeing more than 30 an hour. They're great, they're fixed, healthy as can be, but they're also drinking 6 to 7 liters. So my point on the case report was that you need to not only look at the value at face value, but you should appraise it in context with the patient. And even if it's normal, it can be abnormal. And that everyone can benefit from expanding their knowledge on endocrine physiology. So I think that was it from that standpoint. All right. Oh, there we go. So hypopituitarism. So there's a couple ways you could distinguish this. There's hypopituitarism and then there's pan-hypopituitarism. Hypopituitarism means that you have a deficiency in some of the pituitary hormones. Pan-hypopituitarism means that all hormones across the board are gone. From her labs, we only noted that she had FSH, luteinizing hormone, ADH, growth hormone as deficient. You can never really prove with the TSH because she's being treated, but she still had prolactin. So you couldn't necessarily term her as pan-hypopit. And that's an important distinguishing feature because it's what we would call a semantic quantifier in diagnostics. And it seems like something that's not like important, but it does because it means it's a completely different disease process, which carries with it a different prognosis and sometimes even a completely different treatment. All right. So I think, let's see. I think these were just highlights, right? So we also suspected the patient had a relative adrenal insufficiency. This was kind of cloudy because she was getting steroids for a few days before as part of her regimen. So maybe it wasn't all out by the time she got the stim test, but even with the steroid that she might've had on board, she didn't respond very well to the ACTH. And then sometimes if you have a relative adrenal insufficiency due to like septic shock, your adrenal gland will atrophy and you won't respond to ACTH. So, and then we also knew that the patient had a chronic primary hypothyroidism, right? Because what would be the example of a chronic, of like an acute secondary hypothyroidism on her? Yeah, exactly. For cancer, like took out her pituitary gland and she didn't already have a hypothyroidism. So do we know the difference between like identifying what's a primary versus a secondary endocrine dysfunction? So we're confident on that? Everyone? Okay. Oh, I have more. All right, so here's the causes. I'm gonna see if sarcoid's up there. Mainly, because oh my God, it is. Look, boom. I was like, I think that there is a sarcoid. There is some sarcoid lesions that can cause it. So, bam, Jesse. Who knew? But the main causes tend to be tumors. And then the causes after that is what we're doing to treat the tumors. Resection, radiation, stuff like that. And then there's an interesting one, which was taught to me when I got this lecture from Denise, which is this pituitary infarction called Sheehan syndrome, which happens, this has an illness script to it. And so here's the first time we're gonna hear it. And it presents in a woman who just had a baby who had a postpartum hemorrhage and then presents with weakness. And then she's found to have like severe hypotension. And this is mainly, this phenomenon is not fully understood. There's like some theories out there about why you infarct your pituitary gland after hemorrhaging, but it's a known phenomena in postpartum women. So, yeah.
This is not relevant, but why was your case study patient throwing so many clots?
Oh, that was before she was diagnosed with her cancer because she had a history of DVT-PE. Yeah, so it was interesting because she was showing signs of her diffuse large B-cell lymphoma before she got her diagnosis with the clots.
Okay.
Yeah.
Are you gonna share your slides?
Yes. Yeah. And then the manifestations of hypopituitarism depends on the severity and how quickly it develops, right? Like if you remove the pituitary gland, you're gonna note that on day one, hospital, like post-op day one, day 0. Whereas if it's progressive from like a cancer growing in there, it's not going to be as severe and obvious right off the bat. Okay. Hence, in our patient scenario, right? Like we didn't notice it till like she was there for 10 days and was made an NPO. Right. And then another key factor. So the ACTH deficiency leads to adrenal insufficiency without hyperpigmentation. Why is that?
Like acutely?
So if you have an ACTH deficiency due to your pituitary gland not working, you will not have a hyperpigmentation from adrenal insufficiency. You will have an adrenal insufficiency, but you will not have the hyperpigmentation. Do we all recognize that you can get hyperpigmentation with adrenal insufficiency? Do we know that that's real, that that's a thing? Okay. Exactly. So why would you see it in adrenal insufficiency, but you would not see it in adrenal insufficiency secondary to pituitary disease?
Is it because of the cortisol? Like,
Yeah. Yeah. All right. So we know it happens only in primary AI, but we don't know why. All right. So let's say someone has a primary adrenal insufficiency. What do you think their pituitary gland's doing? The adrenal gland's like, hey, I'm going to just stop working. I'm not going to make any cortisol. What do you think your pituitary gland's going to be like, hey, no, like stimulate. Here's some ACTH. And then something else that it releases with that is a melanocyte stimulating factor, which will make you hyperpigmented. So the hyperpigmentation you see in a primary adrenal insufficiency is due to a compensation that you're seeing from the patient's pituitary gland. Does that make sense? When we tie the physiology in with the disease process. Perfect. And then I put the treatment down here. I'm gonna be fair. I wouldn't expect my colleagues nor myself to know all this dosing in the acute care setting. I imagine we would all look it up. So just know that in a patient with hypopituitarism that's affecting these hormones, these are what's going to be replaced. You do not have to know dosages because I don't have to know dosages. Well, I do, but I will look up that dosage. It's not in the back of my head. All right, so the Sheehan syndrome was an example of an illness script. Illness scripts, just like the framework that I used for my workup for shock, is a way that you can paint a picture in your mind on what something looks like, and it can go from the back of your head to the front of your mind, and you can use it at any time with patient care. All right, so what it consists of is 4 parts. It's usually the pathophysiology, what the patient looks like and the context in which the patient presents to you, their signs, symptoms, and their management. And so, for example, I think the illness script we all kind of hear in the back of our mind and how we learned about MI in our in our nursing degrees, where 63-year-old male with a history of hypertension presents with chest pain, diaphoresis, stating it feels like an elephant is sitting on my chest. Does every patient with an MI present like that? No, but it does bring to the forefront of your mind MI, right? So another illness script that you can keep in the back of your head, and this will tie into stuff we've already talked about. You have a patient, you have a 50-year-old male with a history of lung cancer who presents with seizures, found to have a sodium of 120. What is his diagnosis? Hyponatremia from SIDH, right? So the reason I also bring this up is exams, major national board exams are written off illness scripts, right? Like they write that because if they gave you every sexy, exotic way that a patient could present, no one would pass the exam, right? So if you don't know how the stereotypical patient's going to present, then you're not going to know what happens when the not typical patient presents, right? So we'll tie this into kind of our workup. I think there's a break here. Aha, 10-minute break. Oh. All right, so let's see how well the sound works on this system, because we got some stuff playing here. All right. All right, let's see how creepy this looks. It looked creepy on my computer, just so you are.
Hello, my name is Hillary Thomas. Over the previous 3 months, I've had an increasing weakness with occasional dizzy spells. I have also noticed that I have issues with memory. My hair is thinning and my nails are brittle. What is my diagnosis?
What is this thing?
That's Hillary Thomas.
She's creepy.
Isn't she the creepiest? Yeah. So that's an AI system that you can use to present information, you guys.
What?
Yeah, it's kind of fun. So fun fact about me, I mess a lot with like some AI and informatics stuff because it's part of my research, but that's an AI. Yes.
To be clear, we're not talking about adrenal insufficiency.
Well, when I.
Oh, yeah, sorry. Artificial intelligence.
I was like, AI in blah, blah, blah. And I like thought it was gonna be.
Yeah, I mean, I'm also very interested in AI in the critically ill patient. But yeah, this is AI. So with the information she presented to you, what is her diagnosis? You were distracted by the mouth? I was too. All right, we'll do it again.
Hello, my name is Hillary Thomas. Over the previous 3 months, I've had an increasing weakness with occasional dizzy spells. I have also noticed that I have issues with memory. My hair is thinning and my nails are brittle. What is my diagnosis?
Chinese are way better.
All right, what's your diagnosis?
Hypothyroid.
Hypothyroidism. Perfect, right? So why do you think I picked this avatar to represent hypothyroidism? Perfect. What etiology within hypothyroidism is common in this demographic? Wow, yeah, so you're right, like women in their 40s. But there's an etiology, right? Hypothyroidism,
Yeah, but the thyroid just.
it just poops out.
Yeah.
You're like, oh, I hate when my thyroid just poops out. Yeah, there's a disease. There we go. An autoimmune disorder. Hillary's thyroid didn't just poop out, y'all. Hers, Hashimoto's. Oh, okay. So we have congenital hypothyroidism, which is uncommon, and then we have acquired. The most common, Hashimoto's disease, and then thyroidectomy, and then radioactive iodine ablation therapy, neck radiation. In the outside of the United States, iodine deficiency is actually a common cause of hypothyroidism, and then infiltrative diseases like sarcoidosis can do it. And then the other thing that you should be well aware of is that drug-induced hypothyroidism is actually a little bit more common. And I have a feeling that this is going to move up on the list because as cancer treatments have progressed, we've started doing a lot more targeted treatments. And a lot of these ones, the sunitinib, imatinib, these ones can cause like a thyroiditis and then lead to hypothyroidism. So just be aware in patients who have underlying cancer, they may be getting something that could cause a endocrinopathy. Alrighty. And then that's an artistic thyroid in the back. It's flowers. All right. So signs and symptoms. Once again, so I gave you guys the illness script for it, which is kind of the unique findings that would be kind of odd that should stick out in your mind, like, hey, this patient has hypothyroidism, right? The thinning hair, memory issues, brittle nails. But it's an endocrine disorder, which means it can affect any system in a certain way, right? So hypothermia, hypotension, weakness, fatigue, periorbital puffiness, feeling cold. Signs, things to be aware of. Tachycardia, rare in someone presenting with hypothyroidism. Normal, normocardia, bradycardia, common, right? EKG abnormalities can vary depending on severity, but you can even progress to forms of heart block. And then you can also have presence of pericardial or pleural effusions. And then neck scar, right? Like how it's kind of ironic the amount of times I've seen patients who are like, wait, what's the scar from? And they're like, oh, I've had like my thyroid removed. And you're like, wait, but you're not on levothyroxine. Like, did we get all of it? And so just be aware. And then laboratory findings in severe hypothyroidism, the CK can be elevated. This is called hypothyroidism related myopathy. I'm actually not fully aware of the mechanism behind that, but just be aware you can get a myopathy due to severe hypothyroidism. The other thing, which is interesting and probably would go in an illness script for hypothyroidism, is hyponatremia. It's kind of one of the things I always send when I have a patient who's hyponatremic, because I'm like, maybe I'm going to catch a thyroid disorder. And then hypo or hyperglycemia, depending on what your adrenal glands are doing in response. And then a macrocytic anemia. And then in a hypothyroidism, in this context, it is a primary hypothyroidism. So you're going to note an elevated TSH, right? Because the pituitary gland's like, no, please make more. And then a low T3, T4. All righty. And then Mixodemocoma. So it's really interesting.
Wait, I have a question.
Yes.
So if they had a secondary hypothyroidism related to like a drug or something.
Yeah.
Which was a common drug that causes that?
So amiodarone.
Oh, okay.
Right?
Oh, right.
And that was on your guys'
So,
quiz, right?
then would their TSH be low because they're, or to be, hold on. Because if their thyroid gland works.
Exactly. So it depends on the mechanism in which how the drug is. Like
Okay.
drug-induced is a very broad term, and there's many ways that the drug can do it. It can do it by damaging the thyroid gland. It could do it by taking up more iodine, so you're actually not making it. So then I believe it's by like the iodine uptake.
Yes.
Yeah. And so your TSH, your pituitary gland's working, it's gonna bump up, and then it's just gonna be a low T3, T4.
Right.
Yeah. Right. Good question though. Oh, ooh, how much of that did I repeat for the people on Zoom? The question was.
It's okay. We can hear Kendall. I think I can hear Kendall pretty well.
Because I was like, oh goodness. All right. And then, so Mixodemocoma, it's actually really interesting because in my mind, this is part of like that existential crisis I was discussing earlier with a couple people. It's like, oh, how do we even know these things anymore? What is this? Can we even say this is real? Anyways, Mixodemocoma kind of falls along a spectrum, right? Like you have hypothyroidism, you have what you would maybe say like severe hypothyroidism, and then you have this subset of patients that's called Mixodemocoma. So Mixodemocoma is kind of a term that could be easily thrown around, and it really just kind of depends. Some people would be like, no, that's not Mixodemocoma, that's just hypothyroidism. Like, yeah, they're a little bradycardic, but of course they're going to be. So just be aware. But the key clinical findings, I think if you have more than one thing, like if you're hypothermic, bradycardic, hypotensive, and you're encephalopathic to the point where you're requiring intubation, that to me is a definite like slam dunk Mixodemocoma. But no, it's not dichotomous. It falls within the spectrum. Alrighty, and these patients tend to have a triggering event. So infection, MI, bleed, they have a triggering event. They're an older person who maybe weren't taking their thyroid medication like they were supposed to, then they get into trouble. So that should be what that illness script looks like. Patient with hypothyroidism, triggering event, comes in so sick that they're bradycardic, hypotensive, on a ventilator for airway protection. Alrighty. So Mixodemocoma treatment. So like I said, it falls within the spectrum. If it's severe enough to be truly a Mixodemocoma, they should be in an ICU, should do glucose checks for hypoglycemia, passive rewarming. So essentially you're just putting like warm blankets on them. You're not actually gonna like heat them up because they could vasodilate and their thyroid isn't working. So they're not gonna really like vasoconstrict. So you can actually make their hypertension worse. Although I'm sure you could question that.
You don't give them warm fluids?
You should. Passive rewarming, so just like
I know, but why? Like because
you could
don't really-
vasodilate them and they don't have the thyroid hormone to actually constrict. So if you further vasodilate them and they're hypotensive, the thought is you would make them their hypotension worse. All right, and then treat the underlying trigger, pharmacologic intervention. So this one is kind of a little bit more of an expected medication. You should know that you should give them a load and then followed by a dosing. All right, so it could be 200 to 400 mics times 1, and then 1.2 mics per kilo per IV per day. And then in patients with severe enough Mixodemocoma hypothyroidism, they'll have a relative adrenal insufficiency. And so what that means is when you start giving them some of their thyroid back, their adrenal glands will not be able to keep up with it. So you're gonna have to give them a little bit of glucocorticoid as well. So you'll do hydrocortisone. This could be argued as well. Like if you do a stim test and you're like, their adrenal glands are working fine, and I don't think they're gonna do bad, you can just replace their thyroid and then see how they react. And then if they get, like they decompensate, then you can add some steroid, all right? And then the other thing really is just monitor for complications. This is what we do in every patient who comes in the hospital. Look for a bleed, make sure they're protecting their airway, stick the, what was it? What does Lynn Keenan have in her pocket all the time? Tongue depressor. Have the tongue depressor in your hand, all right? And then monitor for signs of shock, severe sepsis, especially as you're giving people high dose steroids. All right. This is the last one. My thought is if I burn these in your brain and you have nightmares about them at night, you'll remember them. So.
Hi, I'm Grace and I.
She's not as good.
Because I'm not feeling right, mainly irritable and anxious. Additionally, I have lost weight over the previous month and my vision is blurry. What is my diagnosis?
What's her diagnosis? Hyperthyroidism, right? So she irritable, anxious, having some vision issues. She has an elevated temperature, elevated heart rate, relatively elevated BP, and her respiratory rate. Is respiratory rate 26 at rest normal?
No.
Great. All right. She looks pretty chill, right? I was like, how can I get them to get an avatar with like exophthalmos? Yeah, and I was like, that might be a bit much. So, all right, thyrotoxicosis and thyroid storm. Once again, this kind of all falls within a spectrum. And so essentially, it just means there's too much thyroid hormone, and it's to the point that it's causing life-threatening organ damage. So the etiologies, most common is actually in younger women, and it's Graves' disease. I should ask that. And then the next ones is toxic multinodular goiter. Sometimes it's just an isolated nodule, and then thyroiditis, early phase. So the patient with Hashimoto's may present with thyroiditis right first, and then develop hypothyroidism. And then drug-induced thyroiditis. This again is those medications that I kind of want to bring to your attention, those cancer treatments. These patients may present that way. I've actually seen more of this than I would like to admit. And then malignancy, they have a thyroid carcinoma. And then the other thing is if they actually have metastatic disease from a thyroid carcinoma, even if you resect the thyroid and they miss the metastatic disease, they could still go into thyrotoxicosis because it's still secreting thyroid hormone. And then the interesting one that's a little bit common too is self-dosing, like giving yourself higher dosing than you need to, because people think like, oh, I'm going to lose weight, I'm going to have all this energy. I actually had a roommate in college that did that, and it was kind of.
Did they go straight for like T4 or did they just?
I don't know. I didn't ask. I was just like, because he's like, I have a thyroid issue, and then he stopped having a thyroid issue 2 weeks later, and then he was like way on the other end. I was like, yeah, and I was like, I think you're treating yourself a little too well. But it's great. He went to the gym like 10 hours a day. All right. So once again, it's a hormone, so multi-systems can be affected, but the ones to be aware of is actually AFib, a patient presenting with AFib. And then these high output congestive heart failures, right? Like that would be an odd presentation, right? Like if you have a younger woman in her 30s who presents with AFib and she's in heart failure, that should be kind of a trigger. Like that doesn't make sense. Why is a woman that age doing that? And then severe hypertension.
Sorry.
Is it on there again?
No, I was just.
Damn it. I was like, how did I get sarcoid into that one? Okay. ACS, coronary artery spasm, which will look like ACS, right? And then you'll actually cath them and their cath will be clean. And then sometimes patients, especially the ones who are abusing thyroid hormone, will just have sudden cardiac death, which in hindsight, I probably should have told my roommate about that, but I didn't know that, so it's not my fault. Don't judge me. So the thyroid storm illness script. So this is, again, it's more common in women beyond their 6th decade of life. They also tend to have a triggering event followed by this. And then the triad that's commonly cited, but not commonly observed in clinical practice is hyperthermia, severe tachycardia, and CNS derangements. So this is the woman in her 60s who's gone Hulk status in ED, ends up included.
So hyperthyroid in general is most common in young women, but
Yeah.
storm itself.
Yeah. So hyperthyroidism secondary to Graves' disease is common in the younger woman population. Thyroid storm is common in women that are older in their 6th decade of
I
life.
have a question. So
Yes.
you're saying that it was precipitated by like a triggering event. So
Yeah.
would you mean like illness, like an acute illness or MI? Or something?
Yep, infection, MI, GI bleed. It's almost similar to the same list. I don't know if you guys have, it was a longer read, but the thyroid disorders chapter, like if you compare the triggering event list from those, they're pretty close to each other. And then what lab distribution would you expect in a patient suffering from a thyroid storm?
Low GC.
Perfect. All righty. And then trying to remember if this adds anything additional, because I think you guys got it. Let's just go for it. Why not? Re-review.
Learn Efficient presents thyroid function test by Trish Hartman and Mohammed Ashif Muslim, narrated by James Johnson.
That is a vanilla name. Sorry.
Refers to the measurement of levels of three hormones in the blood. Thyroid stimulating hormone, abbreviated as TSH, thyroxine, T4, and thyroid, T3. T4 and T3 that are not bound to plasma protein are termed free T4 and free T3. Measurement of free forms is preferred since they represent bioavailable or active levels of thyroid hormone. So we have TSH, FT4, and FT3. Where do we start? We almost always start with TSH, the most sensitive parameter to evaluate thyroid function for most individuals. The tightly regulated negative feedback loop between pituitary and thyroid ensures that even minor changes in thyroid hormones are associated with reciprocal changes in serum levels of TSH. There are three fundamental principles with respect to TSH in interpreting a TFT. First, a normal TSH level rules out significant abnormalities in thyroid function. Next, a high TSH indicates hypothyroidism. And finally, a low TSH is suggestive of thyrotoxicosis. There are exceptions to these principles, and we will discuss a few later. These must-know facts will serve you well in most clinical scenarios. Let's evaluate each one in detail. A high TSH almost always indicates hypothyroidism. This may be classified as overt or subclinical and is differentiated by FT4 levels. When the TSH is high, a low FT4 indicates overt hypothyroidism, whereas a normal FT4 indicates subclinical hypothyroidism. It should be emphasized that the term subclinical is a misnomer, as the definition is purely biochemical regardless of the presence or absence of clinical features. The causes of overt and subclinical hypothyroidism are similar. The most common are Hashimoto's disease in the developed world and iodine deficiency worldwide. Other important causes include thyroidectomy and the iodine relation. Now, did TSH always indicate hypothyroidism? Of course not. The TSH secreting pituitary adenoma or TSHoma and thyroid hormone resistance, RTH, are rare disorders that should be considered as differentials for an elevated TSH. In these two scenarios, the FT4 is usually elevated. Summing up, an elevated TSH is commonly due to overt or subclinical hypothyroidism, and rarely due to a few other disorders. Now let's move on to a low TSH. Low TSH usually indicates thyrotoxicosis. As with hypothyroidism, this may be overt or subclinical and is differentiated by FT4 and FT3 levels. In the setting of a low TSH, an elevated FT4 or FT3 confirms overt thyrotoxicosis, whereas normal levels of both FT4 and FT3 are indicative of subclinical thyrotoxicosis. It is worth noting again the distinction between overt and subclinical is purely biochemical and not based on clinical manifestations. Now wait, what is hyperthyroidism? Is it the same as thyrotoxicosis? No, the term hyperthyroidism exclusively denotes thyrotoxicosis due to a hyperfunctioning thyroid gland. Two examples will clarify this further. In Graves' disease, thyrotoxicosis is due to hyperthyroidism. That is increased synthesis and release of T4 and T3 from the thyroid gland. On the other hand, thyrotoxicosis in viral or postpartum thyroiditis is due to an excessive release of preformed thyroid hormones and not due to a hyperfunctioning gland. Now let's enumerate the important causes of hyperthyroidism. The most common cause is Graves' disease. Other causes include toxic multinodular goiter and solitary toxic adenoma. Apart from these, hyperthyroidism may also result in very high.
I'm going to just go back to that really quick. Do you guys know what study this is?
What iodine uptake study?
Yep, the radioactive iodine uptake study. And the reason why that's important is essentially you're just giving them iodine. You're going to see if the thyroid gland like how uptakes it. So as you tell, there's a single nodule here that's uptaking more iodine from the thyroid gland. And so that kind of points to like a nodule. And then this is like the toxic multinodular, what was it? Toxic multinodular. There's a third word on there, but goiter, there we go. And then Graves' disease, it's a normal shaped thyroid gland, but it's all taking it up. So. And then by this point in the hospitalization, you probably are having some form of endocrine following this patient with you. Oh no. Oh, screwed it up. Let's see, we'll skip.
Hyperthyroidism include thyroiditis that may be viral, postpartum, or drug-induced, excessive exogenous administration of thyroxine, and rarely ectopic thyroid tissue as in struma overt. Does a low TSH always indicate thyrotoxicosis? Of course not. Rarely, a low TSH could be due to disorders of the pituitary or hypothalamus, leading to impaired secretion of the hormone. This may result in secondary hypothyroidism, where both TSH and FT4 levels are low. Summing up, a low TSH is almost always due to or subclinical thyrotoxicosis. This may be due to hypothyroidism or other causes, and rarely due to secondary hypothyroidism. There are a few other scenarios that may result in altered thyroid function tests. Here, TSH may be normal, high, or low. An interpretation of TFT can be challenging. These include non-thyroidal illness, drugs, and assay interference. NTI or sick euthyroid syndrome may manifest in the setting of severe systemic illness. Many drugs can alter TFT. A detailed review of medications may point to the causative agent. Finally, assay interference should also be considered as a potential cause for discordant TFTs. A detailed interpretation of these scenarios is beyond the scope of this video. This slide summarizes our discussion. This one provides a sample reference range.
Wow. Flew through those slides.
Interact with authors, search.
No one cares. All right. So for exam purposes, both in this exam and I think in boards at least, for me personally, like I don't expect anyone to memorize labs, at least like some of these more exotic labs. I think you'll get shown through your clinical practice if you deal with these labs frequent enough. In regards to board exams, they tend to give you labs like these, but they tend to present it in a way that's very obvious. So like it'll be a very obviously low TSH or a very obviously high TSH. They try not to trick you and give you borderline values. Right. So thyroid storm treatment. So the treatment for thyroid storm is a little bit more trickier than hypothyroidism. Because you're blunting some of the effects of the thyroid that's already kind of done some damage, and then you're also trying to prevent further release and synthesis of the hormone. So each regimen should have 6 parts. So the first part should be either PTU or methimazole to inhibit thyroid hormone synthesis. The go-to agent, I'm going to be honest, the last time I had a patient that we thought was thyroid storm, it tended to be methimazole, and it was under the guidance of endocrine. So just know that one pillar of treatment is inhibiting the synthesis. The next pillar of treatment is inhibiting the release, right? Because it doesn't help that you're, if they keep releasing more hormone. So, and I believe during my last case, we did potassium iodide 5 drops every 6 hours. And that's just so that you don't release anymore. And then the next part is really just blunting the effects that the thyroid hormone is having on like the heart, the blood pressure, the kidneys. And so propranolol or metoprolol, some form of beta blocker. And then next is to inhibit the conversion from T4 to T3. You do that with steroid or propranolol. I'm going to be honest, I didn't read too much into these mechanisms. I bet they're pretty interesting on how, because I'm sure these are 2 very different effects on how they would do it. and I'm not sure which one they would favor, but I believe dexamethasone is first line. And so if for some reason you decide propranolol because you're like, oh, we're going to treat both of these, then you still need to have some steroid on board just to treat a relative adrenal insufficiency. And then you augment clearance, and it's cleared by the biliary tract and then out through the stool. All right. So once again, this one, definitely do not worry about like dosaging. Just know that these are the things that you're trying to treat, these pillars. So those headings. All right. And how am I doing on time? Great. Did we just had a break, didn't we? Yeah. All right. So this next part is an activity. And without me even planning it, there's 3 groups and each person has 1 person out. So each group's going to need to call someone. And this was due to randomgroupgenerator.com. All right, so the plan is we're going to break out into these pre-assigned groups. Each group is going to tackle this order. So Sarah, Ebby, Sam, Lydia, Tanisha, you're going to take on hypercortisolism. And then Ali, Tracy, Alex, Rachel, Jesse, you're going to do adrenal insufficiency. And then Chitty, Phil, Kendall, Kaden, hyperaldosteronism. All right. Or what you're going to do is you're going to create an illness script that you're going to share with the class so we can all kind of learn together. So this has got to paint a picture in your mind of what this patient would look like. It doesn't have to get complex, right? Like you're going to see that there's a list of like 30 signs and symptoms a patient can have, but which ones can you pick out from that would make this patient stick out in someone's mind and make them think of this disease state, all right? So we're going to create an illness script for it, and it's got to include who they are, what context that they come in, their mechanism, their manifestation, and their management, all right? And the important part is it's brief and it's unique so that we can pull it in the back of our heads when we see these patients later on. So you guys will have 25 minutes to discuss, and then each group will present over 10 minutes. Yeah. So emphasis on brief and unique. I'm not looking for like, this hormone goes to the adrenal fasciculata and causes this and that. I don't personally care about that. Your classmates might. But I just want to see you guys take all this information and put it into something that's workable.
So all 5 of us in the group who are on
No, just one illness script. So you guys will come together to come up with one illness script. Yeah. And ideally, everyone would offer some part of the presentation, but I understand that like that kind of gets tricky. So just do what feels right. All right.
How do I communicate with my group?
Jace, I don't know if you mute us, but you're muted.
I don't mean to speak. I'm not wanting to speak at the moment.
That is just so we can hear everybody else talk.
Oh. Yeah, no one else was talking either.
Wouldn't have known that.
All righty.
Will, the next time Jesse's in your group for a 10-minute.
I'm just come to accept that, like, there's Jesse, and then I hired me.
No,
The rest of us
there's
don't
not
The
just
rest
you,
of us
all
can't
of
lose.
us.
All right, so let's start with the adrenal insufficiency group.
But Ali ran away.
Ali ran away. All right, we'll give it a couple minutes for Ali to get back.
Okay. Oh, you guys might get the donuts. No cars, so.
Oh, resume recording. Oh, I never paused recording. Wait, no, I did. I had to. That's right. When you guys re-review this recording, there may be a 25-minute interlude. You may have to skip through. Whoops. All right. So let's start with the AI group. AI has adrenal insufficiency. Yeah, this is a warm-up because for your guys's projects, you're gonna have to present complex things in 10 minutes. And they time you and cut you off.
Perfect.
So I don't even know if you need that unless you're very.
Yeah, right.
Where's our? What is that illness look like?
Is it with this that we click?
Is it
Oh,
that
yeah.
one? Yeah, can we just do the arrow?
Yeah.
Yeah, get after it. Play part?
Or
I don't know. How do you advance the slide?
click on it. Oh.
Oh,
Nailed
there we
it.
go. Okay, our patient is a 57-year-old Caucasian female. Previously, a history of hypothyroidism. Presents today with flu-like symptoms, lethargy, malaise, headache, circulatory collapse, and a recent 20-kilogram weight loss, also with some skin darkening.
Thank you. You need space to move
I
around.
don't know where to go.
I'm sorry.
Okay.
I'm trying to help you. Oh my God. Oh, that's me. All right, friends. So our mechanism here for adrenal insufficiency, the adrenal cortex produces 3 hormones, steroid hormones, glucocorticoids, such as Bueller, cortisol, Mineral corticoids, such as, get a girl, and androgens. So the primary AI occurs when the adrenal glands fail to release adequate amounts of these hormones to meet our physiological needs, despite the release of ACTH. So in primary, your ACTH is what? High, while the others are low. So this shows here, primary, we have low cortisol, low aldosterone. And acutely, this can be from a massive adrenal hemorrhage. Most commonly is an autoimmune disease such as Addison. And we already talked about how this usually happens in affluent countries such as our own. And drugs can do this, hemorrhage, infiltration, you know, the things. Manifestations.
Okay, so your patient may complain of recurrent abdominal pain. They're going to have other GI symptoms, nausea, diarrhea, constipation. They're going to have weight loss, but salt cravings. They're going to have low blood pressure, and they can have orthostatic hypotension. They're going to have that hyperpigmentation. They're going to be tired and have myalgias and arthralgias. They're going to be potentially altered, and they may be psychotic. If it's a woman, will have a loss of interest in sex potentially, and they can have decreased pubic or axillary hair, and they can stop having their period. Laboratory findings include elevated potassium levels, low salts. They can have prerenal azootemias, hypoglycemias, and other disorders. Tracy, you're up.
So some diagnostic testing that we should be doing on these patients, drawing a CBC BMP. We want to check all their levels. I think just with any patient that comes into the ED, check a blood glucose level. Generally, those will be pretty low. And get a CT of the abdomen of chest just to check the patient's adrenal glands. An ACTH, obviously, thyroid function tests, cortisol levels, ideally in the morning. A low sodium and high potassium, low glucose and low cortisol level may indicate you towards an Addison's disease. And then once the patient is stable, doing that ACTH stim test that we talked about will confirm your diagnosis. In all cases of adrenal insufficiency, there will be a low sodium, low glucose, and a high eosinophil count.
All right, and this is a table from the up-to-date. So these are management of the AI. Of course, we want to correct all the electrolyte arrangements as well, but obviously they're not having enough the mineral corticoid and also the glucocorticoid. So you can give them hydrocortisone, 100 milligrams intravenously, bolus followed by 50. That's stated there on the fourth line down. And then of course, later on, once they're stable enough and they're more subacute, you can give them the fludrocortisone, because usually we correct that with fluids already and stuff like that. So we don't have to really worry about the aldosterone as well as much there until later when they're more stable.
You bring up one very good point here. Wait, you should be aware of. So as you're tapering someone who's coming in with an Addisonian crisis, you're going to get it to a point where your amount of mineral corticoid you're giving them stops with the steroid. And so you're going to have to give them mineral corticoid as well. So as you can tell, once you get to a low dose of prednisone, you're going to also have to add fludrocort so that they get mineral corticoid as well when you're tapering someone in an Addisonian crisis. Sorry.
And that's it.
Great.
So far.
So, we added some layers. This was the trilogy of the patient with the AI. So in a one sentence, what am I trying to say? I don't even know.
Like a headline?
Yeah. Oh, sorry. So what would be your problem, your impression of this patient? Like one sentence. Yeah, one liner. Oh my God. I was like, what's your one thing? Yeah. Yeah. So give me your one liner, like that one liner that will paint this picture in everyone's mind of a patient with AI. You kind of said it. So you said like a 57-year-old male. Is that the best representative of this? Female? Oh, sorry. So in my illness script, JFK is the patient with AI.
Oh, really?
Yeah, because he has Addison's disease. So sorry.
Had? Or are you one of those that like thinks he's still?
No, he had it, but he doesn't have it anymore because he doesn't have anything. I also feel bad that I went like here when I said JFK. Sorry, I don't know why that was. JFK is a very interesting person in my mind. Anyway, so 57-year-old female presents with
Altered mental status and complaints of
fatigue and abdominal pain. So presents with fatigue, abdominal pain. There was one more. What was it? Weight loss.
and low blood pressure.
All right.
And hyperpigmentation.
Found to have hyperpigmentation, low glucose, low BP, and then there's this very interesting electrolyte distribution on this patient too, right? Perfect. See, so it's this very unique, concise presentation in our mind of what this patient would look like. So then when you do get that patient who rolls into your unit and you notice this like low blood glucose, high K, low sodium, you're like, wait, something seems odd. There's a pattern here that I've recognized before, right? Excellent. Solid work. Yeah. Awesome, you guys. Kaden is not impressed with the PowerPoint. All right.
You will never reach that bar, so go get your hopes.
So you guys, I'm sure you can't see that board very well, but I'll take a picture of it and put it in the module.
Oh.
So.
Thank you.
Awesome. And then our next group, Hyper-Aldosteronism.
I believe in all of you.
Oh yeah. Pass the magic.
My voice carries.
Yeah, Kendall doesn't need to have it.
We'll just set things down here.
Okay.
Thank
I
you.
also put this on here. You zoom in, you zoom out. Oh, wrong thing. Look, I put this on here too.
Oh, look at you.
That's a nice one. We
What's
should have
our
just found that.
I know, right?
Initially. I can do the illness script first.
Okay.
Let me just zoom on this. Wow, your old one. Okay, for hyperaldosteronism. So we're in the ER. We have a 50-year-old male who comes in with headache, facial flushing, some generalized weakness, and he is found to have hypertension with blood pressure of 190/103. His potassium is 3. He takes Grapamel every day for hypertension, and he took it this morning. He's given IV labetalol with no response in his blood pressure. He's maintaining right around 200, 190 to 200 systolic. Perfect. I should say other labs that we want to do are an EKG and troponin to rule out any cardiac causes. And these are both normal. We are going to send, we do an ABG. He's found to have a metabolic alkalosis. And then we'll check, we're suspicious of hyperaldosteronism. So we're
very suspicious.
So we're going to check aldosterone run-in ratio in the serum. And that is found to have, he's found to have low plasma renin and elevated plasma aldosterone.
Yeah.
Yep.
And so you can have primary aldosteronism, which is the most common. You're okay. I kind of have them both here. And that just has to do with the RAS system. And so if you have low renin, you're going to increase your aldosterone, and that can have effects on sodium and water retention, which can cause the hypertension. It's usually due to the bilateral idiopathic hyperplasia, cortical hyperplasia is the most common, and it's mostly common in men. So there is a unilateral one that is most common, or is usually caused by like an adrenal adenoma. Let's see what else is on here. Yeah, I think that's all I have. Do you want to do lab stuff?
Sure.
Or whatever the next step is.
Treatment.
Okay, for treatment, we would give spironolactone as the first line treatment because it's a potassium sparing diuretic.
And it blocks the action of aldosterone.
You could also do an ARB, ACE and an ARB, and this prevents secondary complications with ventricular hypertrophy.
No, we want to prevent secondary.
We want to prevent secondary complications such as ventricular hypertrophy, arrhythmias, MI, AFib, and metabolic syndrome.
So the beta blocker won't work in this instance because this has to do with the RAS system. So you actually need to block the action of aldosterone in order to decrease the hypertension. And then we're worried mainly about arrhythmias because these patients can become very hypokalemic just because the excess aldosterone stimulates sodium retention, which can then also increase increased renal plasma, renal potassium excretion. So I think the biggies with the hyperthyroidism essentially are trying to decrease like the secondary complications. So you have to figure out why they're having the hypertension, and then also you want to fix like the electrolyte abnormalities so you don't and so we're not causing any cardiac complications. And then especially with sustained hypertension, that can cause cardiac complications, stroke, things like that.
So you brought up some unique stuff too, which I think is important, which is like potassium, metabolic acidosis, and the not responsive to IV beta blocker, right? Because if you have a similar patient, material male, with facial flush and hypertension, found to be hypertensive and responsive beta blocker, what could be a possible diagnosis? That's also a good adrenal gland. They're also thyroid. Adrenal gland.
Hypercortisol?
Not that part of the adrenal gland.
Just something.
What else does your adrenal gland do?
Adrenaline or epinephrine. And
Yeah, so
norepinephrine,
epi and norepinephrine. So pheochromocytoma, right? Those release.
Yep.
I was about to say
duh.
But see, you guys notice the mechanisms underneath. You just have to get the diagnosis.
It's kind of tough though, because I wouldn't know. Like if this person came, I mean, there's so many things you could be like, oh, they're just like hypertensive. I don't know. I mean, I'm just saying like what, and it really, they can sometimes be hypokalemic, but sometimes just normal kalemic.
Well, how often do you think we nail this diagnosis right off?
Probably not very
Exactly.
often.
Yeah. But
Because we thought this was hard to just digest.
Yeah. But you painted a stereotypical picture so that when you do have a patient who's not responding to IV beta blocker, but it's metabolic acidosis, then you can start to look into this. Perfect. Excellent.
Okay.
Great job for just winging it.
Metabolic alkalosis from the renal.
Yeah, the increased bicarb is coming from, is what I read, is coming from the RAS, because
I guess your kidneys would be. I'm not. Quite
hang on.
So like acid loss from the kidneys or like
It says, where did I read that?
So that makes sense for like the blood pressure and sodium and potassium as far as the.
It's back down to the fundamental reason what aldosterone does, right? So retains potassium, and then you get rid of K, and then things that go with the K is hydrogen ions, so acids. So you lose acids with that as well, right? Because acids follow potassium, right? That's why you get hyperkalemia with metabolic acidosis, even though it's not like a true hyperkalemia.
Sorry, I was gonna add something to what it said. So
Oh, yeah.
we also do lifetime changes on the hypertension, like the blood pressures and all that. Like, I'm just saying, based on what we're talking about, I know I didn't say anything on the presentation.
Yeah.
So we can also work on their blood pressure by their managing their lifestyle changes and also restricting their sodium and managing their weight.
Yeah. Yeah, that's a good point on the sodium as well, right? Because of the, all right, because of the chaining of sodium. Good point, Chitty. All right, so that leaves us with hypercortisolism. I felt like I missed a syllable when I said that one. Hypercortisolism. No. Okay. All right, this time I'll be better about writing. I missed it halfway through. I'm standing on the side. Test a picture with your words.
All right, so our patient is a 35-year-old female presenting with complaints of lethargy, abnormal facial hair growth, ease of bruising, menstrual changes, and truncal weight gain. She appears round in the face with a dorsal fat pad and is hypertensive.
Yeah, as you can tell, I got hung up on my 35-year-old. All right, so let's distract. Let's take
Three.
because you don't want to make it too complicated.
Definitely the round face and the truncal weight.
But I don't think that's rounded face.
I mean, everyone else calls it round face.
I know. I try to be sensitive to these things. I wouldn't want to be called mean face.
It's a good point.
It's true.
Like, oh yeah, your moon face.
Yeah. Sun face. Sun face to me sounds like okay. 'Cause it's like, oh, right. Maybe sunburn, but yeah.
Melon head. Okay, what's talking point?
The process.
Process. Okay, so
That's what I'm thinking.
we've determined they have hypercortisolism, and as far as the reason, like why hypercortisolism causes these things, or the cause for hypercortisolism is in the name increased levels of cortisol. So we've got kind of three main reasons. Either we gave our patient cortisol, their adrenal cortex is making more cortisol, or their pituitary is pumping out more ACTH, which is going to produce more cortisol. Within that, I guess there's also ectopic tumors that can be producing the cortisol as well. So kind of have to, that's like your three main paths of where to go as far as tests go to reconfirm that this is our diagnosis. We have the nocturnal saliva test, where it's kind of a newer test, but it has really good sensitivity and specificity, it looks like so far. You have the patient spit into a special tube overnight. At night is when our cortisol levels are the lowest. So those supposed to have really low levels of cortisol. If they have high levels at night, pretty indicative that they have hypercortisolism. The next test that we can do is a 24-hour urine cortisol collection.
Urinary free cortisol.
Free urinary, 24-hour urinary free cortisol test. You have them collect their urine for a day, measure the amounts. If it's high, they have hypercortisolism. And then the third option is the high-low dose dexamethasone test. There's kind of two main ways to do it that I was reading. The most common one is you give them a dose of dexamethasone the night before, and then you have them come back in and draw their blood in the morning. They should have a low level of cortisol when you do this test. Dexamethasone should cause a suppression in the ACTH in normal people, and so they'll have a low level of cortisol. If they have hypercortisolism, you give them it and they're still going to have high levels in the morning because it's like a tumor that's producing it, or they're still taking their home steroid
Very good point.
dose.
Sorry, I don't want to interrupt. I want to make sure everyone hears that. So dexamethasone will not interact with your cortisol laboratory assay. If someone's on hydrocortisone or methylprednisolone, it will, but not dexamethasone. So just be aware, because some people do like a cortisol test and they'll be like, oh, well, you're on hydrochlor for days, so it's useless. But then someone will be on dexamethasone, like actually it's not.
No, thank you. If the levels are low, that's normal. Levels are high, that indicates the hypercortisolism or Cushing disease. That's kind of the end of my test there anyways.
Once you know that they have it, then you can kind of differentiate the cause, whether it's, and you'll do that based off of like testing your ACTH and your cortisol levels. And if you have the high ACTH, then you need to scan their brain. If they have the high cortisol levels, then you need to scan their abdomen, because it's most likely, I mean, there's those rare ectopic ones, but it differentiates whether it's a pituitary tumor or like an adrenal tumor.
And then management, usually surgery is the go-to for the management of this patient, but there's some patients that might not qualify for the surgery. They might have some contraindication for the surgery. So for those ones, there's some drugs that can be used to suppress the production of cortisol. So they can use medications like adrenal enzyme inhibitors or glucocorticoid receptor antagonists to manage those. So that's usual, but just know that surgery usually they prefer, let's say they prefer or they recommended, but not everyone will qualify for that.
You might give me an example of one of the drugs.
One of the drugs is a ketoconazole. I don't know if I'm saying that right.
And then let's refine your guys', oh, sorry. I think there's one more people.
No, we
kind of figured it was going to be hard to do through the phone.
Yeah.
So we thought we'd take over the
To make
talking
sure I'm not
part rather
sponsoring
than,
anyone else's.
Yes.
no,
Everyone's
Tanisha
fine.
offered, but we were like, well, it seemed easier than holding up a speaker for the class.
Perfect.
So this-
So let's refine this illness script just a little bit. So we have a 35-year-old female. Where do we think this gal's likely to present with her symptoms? Is she gonna like go crashing into an ICU somewhere?
No.
Probably like primary care, ER.
Right, so she's gonna present her PCP. We're gonna catch this mainly like as like a side, like she'll be admitted for one thing and we're gonna catch this as another thing. So let's just say she presents her PCP. Right, elevated BP. What's a PF?
I don't know. I don't ask you.
Elevated
knows
PF.
Yes.
Her husband, her boyfriend also has truncal PCP, rounded face. And then in the PCP's office found to be hypertensive, hyperglycemia. Is there anything else that we could add to make this patient unique, stick out?
I think that like the skin, like easy bruising or thin skin.
Yeah.
would be-
Especially in a younger
Red
group.
marks, striae.
Perfect.
And they can have, even though they are obese, they may have thin arms and thin legs.
Yeah.
All right, so excellent. And then notice like the first treatment on each of these, right? Hydrocort, spironolactone, surgical resection, right? So does that make things at least a little bit more simplified in your guys' mind on like how these patients look, right? Hopefully you can pull these to the front of your mind when you see these patients. Excellent, you guys.
I think.
So yeah, I'll take a picture of this. We'll put it under the module so that you guys can all see it. So it's all
Thank you.
available. And then I also have some notes that I've made separately with these 3 disease states that'll post in the module. Essentially, it's similar. It's just actually your guys' might be a little bit more in depth than the notes are. But the notes are fair game for exam. And you guys know more than the notes. So you guys should be okay. All
I have
right.
a question about hypercortisolism.
Yeah.
I spend a lot of time trying to. So the steroid use, like the tumor makes sense, not
Yeah.
too much, whatever. But the steroid use is just because instead of having like normal bodily like fluctuations in the cortisol, so you have some release.
Yep.
And like release when to go.
Yeah.
And when they are on it consistently, it's just like a continuous amount of. Do you know what I'm saying?
Excellent question. Yeah, so this is a question I'm not muted or anything, right? So yeah, this is a question on drug-induced hypercortisolism. And you're right, in normal endocrine physiology, your adrenal glands release things in a pulsatile manner according to how your body works and how it regulates. And when you have a drug-induced, you're kind of just giving them extra steroids twice a day. And so, and most of the time it's super therapeutic. And so it's usually super therapeutic if people are starting to develop these signs. And so that's why the goal of any patient who goes on steroid therapy is to get them off of it or get them on the minimum dose necessary to treat whatever it is that you're treating. Did I answer that for you?
Yeah, because I was just, it talked about how that inhibited your pituitary to release ACTH. And so it's kind of backwards because it's not like the tumors.
Yeah.
And so we were trying to grasp it all.
Yeah. Yeah. And I'm sure there's like, whenever you think of manifestations when it comes to a patient, your manifestation is either due to the disease process itself or due to how your body is compensating for that disease process. All righty. Clear as mud.
On the dexamethasone, so like short term, like it's not gonna affect the cortisol test like for short term, but what if somebody was on dexamethasone long term? I mean, is that still gonna lead to Cushingoid symptoms, like right or no?
I don't actually know off the top of my head for long term. I don't think it does, but I do kind of see like if you're on a high enough dexamethasone dose for a while, I could see maybe why you would suppress maybe some ACTH, and so then maybe that would throw off your cortisol.
Yeah, I believe that you can.
Yeah, so I could see maybe in long term, but definitely in short term, dexamethasone would not affect your cortisol assay. Awesome. Any other questions, concerns? You guys did that with half an hour to spare. I know. Huh?
We're just like really smart.
You guys nailed it.
So it's like dexamethasone is like the safer.
I don't think it is actually. I just don't think it's the go-to drug for a lot of regimens. And so it's not used as commonly. Like, to be honest, before COVID, dexamethasone was like isolated to maybe like post-op neuro or like cranial or any like intracerebral edema or like cerebral edema. Yeah, nausea and vomiting for chemo regimens. Like those were the kind of the silos in which you use dexamethasone. And so I don't think that it's less. I just think it just happens to not be as commonly used as the other steroids. And there is some level of potency with each steroid too, right? Like your hydrocort, your methylpred, and your dexamethasone all have a different level of potency. And so that's why certain regimens for certain things will treat it. So that's why like for like the most potent is like the hydrocortisone. So that's why it's like your go-to for your like Addisonian crisis. Although you probably could find a dexamethasone equivalent, the dosing would be higher. Yeah. 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 Yeah.